Hello, thank you for the introduction and for the invitation to speak here today, and thank you all for coming. So I'm going to be talking about how why assessing consciousness can be a problem in certain, or a challenge, I guess, in certain clinical cases, and what can we do from the area of neuroscience to try to tackle these clinical challenges. So for the purpose of the next 20 minutes, I know there's no a definition of consciousness that we will all agree with in this room, but and you'll hear much more refined definitions of consciousness in other talks today. For the purpose of the next 20 minutes, I just want to use a very, very simple definition that consciousness is your ability to have subjective experiences of your surroundings and yourself. So you may have been in a similar situation than this, or perhaps in this very same spot, but your experience would be unique to you and different to the experience of the person in the picture. And even right now, your experience of looking at this picture in the screen is going to be different to each of you and unique to each of you. So I want to do a little exercise before we move on, which is just kind of stop listening to me for a second and then think, are you conscious? So hopefully all of you will say, of course I'm conscious, I'm here, I'm listening, I'm understanding, I'm having an experience, I'm finding you interesting or boring or whatever. So that one's 61. So now I'll ask you another question that is hopefully a little bit more complicated, especially in this room. And then I'll ask you to look at the person sitting on your left and think, is this person conscious? So I'm not going to ask you to answer or to point at anybody in here, but hopefully you appreciate that this is a trickier question, because if you know the person sitting next to you, maybe you walked into this room with them, you've been having a conversation with them, you've been talking, and you say, of course they're conscious, I'm my friend, I've been talking to them, and they're responding to me in a way that makes me think that they're conscious. If you haven't met them before, maybe you have some doubts, maybe not. But at least you can appreciate that this is a tricky question. One of the reasons why it's tricky, the main reason why it's tricky, is because we can't access their experience, we can't access their consciousness. I don't have a magic tool that I can wave here in the room and say, conscious, non-conscious, conscious, non-conscious. And what we do is we attribute consciousness to the person sitting next to us. So all that's well and good, and if you're into science fiction, you may recognize this movie. There's been many, many, many movies in which the main character is tasked with determining whether the machine, in this case, is or not conscious. So if you haven't seen this movie, here we have a clearly artificial entity, and they're not doing anything to hide the fact that she's not human. And Caleb's task, he's a psychologist, and he's tasked with talking, having conversations, having interactions with Ava, and just to decide whether she is or not conscious. And sometimes this is defined in the context of artificial intelligence as a Turing test. So now you're saying, what does this have to do with patients? So this is to kind of emphasize the concept that we can't access somebody else's subjective experiences. We can't access their consciousness. And all that we can do as clinicians, in this case, is to assess them and to do an attribution and to make an informed guess about whether the behaviors that this patient, in my case, is exhibiting correspond to what I consider a conscious entity to behave like. Okay? So, the patients that I work with, in particular, are patients who have had a very severe form of brain injury. Most of the time, this is a traumatic brain injury, the type of accidents that you see in very serious car crashes. There's other types, but that would be the most common one. So the patient has their brain injury, they go into a coma. Now, many of you would be familiar with coma. This is what is typically displayed on the telly and in the movies when the person has their eyes closed, they appear to be asleep, and they're connected to a machine that goes beep, 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 beep. So, that's a bit. So, that machine is helping them breathe and is kind of keeping them alive. So a patient in a coma is not conscious, they're not even awake, they can't be woken up. Now, many of patients in a coma will wake up and go back to their lives with certain levels of cognitive deficits to a degree or another. But my patients, or the patients that I work with, wake up in the sense that they open their eyes, they stop needing the machines to kind of keeping them alive, the bodies recover, but they have sustained such severe type of brain injury that they appear to be entirely unconscious of what's happening around them and what's happening inside them, if you like. So they appear not to be having any conscious experiences of the world or themselves. And these are patients, the diagnostic categories are the vegetative state and the minimally conscious state, and the difference is the severity. So patients in a vegetative state are considered to be entirely unconscious or unaware, and patients in a minimally conscious state are considered to start recovering some signs of awareness, but these are very minimal and very unstable, if you like. So again, to emphasize, even if the clinical definition is that these patients lack awareness, what we mean is that they lack evidence of awareness. And when we go and test them, we cannot see anything that makes us as makes the clinician believe, although I do take part in this part of clinical assessments, make them believe that the patient is aware. So there's no evidence. And just to give you an example, the type of behaviors that we see in these patients are all behaviors that can be explained by reflexes. So if you apply pressure to the nail bed, they may move the hand, but you don't need cortical, you don't need brain responses for this type of behavior. It's a very basic type of response, but they won't do anything more complex. So, so what happens in this case when very severe type of brain injury has stopped your ability to communicate, has stopped your ability to speak, and has stopped your ability to interact with the world in the way that we can all interact with the world? So you would receive a clinical assessment, and they would consider this person is not responding the way we think a conscious person should respond, and therefore they are unconscious. Okay? And the way we do it, when we can't effectively speak or talk with a patient, is by asking them to follow simple commands. So in the clinical assessment of disorders of consciousness, command following is used as a proxy for awareness. So this means I talk to you, and now instead of having a conversation, I can say, okay, if you can understand me, if you hear what I'm saying and can understand me, can you lift your hand? And you may not be able to speak, but you may be able to do these behaviors. Okay? So I'm going to show you now a video. This is one of the patients that I've tested. This is from a BBC documentary, so it's an excerpt from the documentary. And in this case is his mum is talking to him, just so you have an idea the type of behaviors these patients can show and how tricky they can be to interpret. So in this case, what was happening is that his mum was trying to ask him whether he was happy to come to the lab again for further testing, and we see that the patient does a thumb up. So you think, amazing, the patient's communicating, he can do this response. The problem is that this response appeared all the time, and it appeared when we touch his hand as well, even if we were not asking any questions. So these patients move, and they do spontaneous movements, and the real tricky thing is to think, okay, does this mean that the patient is following the command, in this case answering the question that his mum is putting in front of him, or is it just a purely reflex response? And thus, can we interpret this thumb movement, which is the only thing this patient has done in these brief few seconds, as a sign of consciousness or not? And I've got another video. Just not showing up yet. There it is. Where this problem is highlighted by the parents of a different patient. So hopefully you can appreciate that the clinical assessments in these patients is really, really tricky, and decisions are being made on the basis of these clinical assessments. Whether the patient is considered to be conscious or not is going to determine the clinical path that is offered to that patient. It's going to determine certain legal decisions that are going to be made about these cases, and it obviously has huge implications in terms of the attitudes of their family and caregivers to understand whether this person that they're looking after is conscious or they aren't. And the clinical assessment is really, really tricky, it's really difficult, and it's really prone to error because of this type of behaviour is being confusing, difficult to understand in patients who behave like this. Okay? So what can we do about it? So something that we can do that is really, really exciting and that we've been doing for a few years now is maybe we can assess the ability to follow commands in these patients, and again think about command following as the proxy to determine whether somebody is conscious or not in this clinical setting, in a way that doesn't depend on the patients producing some of these very noisy, very tricky to interpret behavioral external responses. So what we can do is we can put the patient in an MRI scanner. That's an MRI scanner, and that's one of the patients that I have tested. So for those of you who are not familiar, this is a big scanner with magnets, radio frequencies, and some very clever physics. And we can take static pictures of your brain that saying that if you were going to go for an X-ray, that can tell us whether your bone is broken or not. So we can take pictures like that of your brain that tells us about any potential damage that you can have in your brain. The cool thing about it is that we can also take dynamic pictures while you're doing something. And with this, we can see what your brain is doing while you're doing a particular task that we're asking you. Okay? So now I can ask you to do command following. I can ask you to imagine, to lift your hand, etc. that we were saying. But instead of asking you to produce a response, physical response that I can see with my eyes, I ask you to produce a mental response that I can see in the MRI. Okay? So specifically, well, and this was developed by Adrian Owen in Cambridge in 2006. So what they did in this study was to test a patient who was in a vegetative state for, I think 6 months she was, after traumatic brain injury, and they asked her to imagine she was playing tennis. This is because if I ask you to move your hand like this, in the scanner, while I record your brain activity with the fMRI, this bit of your brain, which is the bit of your brain that controls the movement of your right hand, is going to light up and I'm going to be able to see it. Now, if I ask you to stay still and imagine that you're moving your hand, there's a different part of your brain, which is the part of your brain that is responsible for planning your movement, that I'm also going to be able to see. And this is a supplementary motor area, and it's this area that you can see here. So what you can see here is heads looking this way and a slice through the middle. So the blobby color things are the brain activity during this task. And you have the activity that you can expect in healthy participants. And here you have a patient who was entirely unresponsive. Her brain looks different. She had very severe brain injury, but we find activity that can only be there if the patient understands what we're asking them to do, decides to do it voluntarily, and sustains that ability in blocks of 30 seconds for a whole 5 minutes. So it's quite a complex task. So these patients who appeared like the patients that we've seen before could do this task and show us that she could follow commands and therefore she was conscious. Now, I have no idea what it feels to be this patient or what type of experiences she's having, but to the extent that she is following commands, I can say that this patient has the ability of consciousness. She's conscious from a clinical perspective. We have a second task. The second task, we ask participants to imagine they're walking around a familiar place. Imagine that you're walking through your house, looking what's on the walls, what's on the floor, you walk into a room, etc. And the reason for that is because we have the same idea that we have activity in bits of the brain that control spatial navigation, this is called, but in this case it's different to the activity in different parts of the brain that the activity associated with imagining moving your hand to a game of tennis. So why is this important that we have two tasks? Because now we can take it one step further. We've used this task in hundreds and hundreds. We and others, many labs in the world have used this task now in hundreds of patients, and we know that there's evidence that up to 20% of patients who appear vegetative and considered to be entirely unconscious are actually aware and can do this task. So, and they have been misdiagnosed simply because clinical tools can't capture these. So we have two tasks. So now, the really nice thing about it is then we can use them as a communication device, so to speak. If I have two tasks, now I can ask you a number of binary yes-no questions, and I can ask you to imagine you're playing tennis. If the answer is yes, and imagine you're walking around the house if the answer is no, or vice versa. And we can do it a few times, switching the labels just to make sure it's all rigorously tested. So we've done this in a few patients, one of whom is the patient in the picture, who had been in a vegetative state for 12 years after a car crash. He had been assessed by many experts, and at no point he had shown any signs of being aware. All we can get from him was behavioural responses. I personally tested him with standardised behavioural scales over 20 times for the period of over 2 years, and at no point I could find anything behaviourally. Yet we put him in the scanner and we asked him, imagine you're playing tennis, and if he imagines something like this, and boom, Now you're looking at his brain looking this other side, so it's a bit confusing, but I should flip the image, sorry. But it's the same thing. You have a head looking that way, and you have a slice through the middle, and you have a yellow area of activity that we pick with the fMRI in the part of your brain that is controlling this motor planning, when we asked this patient to imagine playing tennis. So we did this a few times. He was a really, really consistent, reliable responder. So then we decided, okay, so now we can ask you questions. And we start with questions that we can verify, so boring questions, just because we need to know that the method works and that the patient understands what we're doing. So we ask, is your name Tom? His name wasn't Tom, I'm using different names for confidentiality, but is your name Tom? And then he answers, yes. And hopefully you can see, it looks like a copy, it's not the same image. Hopefully you can see it looks slightly different. It's a different scan of the patient imagining playing tennis to answer yes, that his name was indeed Tom. And then I ask him, is your name James? And then he answers, no, it's not James. So we always ask one question and the opposite to kind of make sure that the method's working. So we verified that, which was super exciting, and this has been done with a few patients as well. And with this patient in particular, we just wanted to then know things that we want to know about. So one of the main things that is attributed to these patients is because they're not conscious, they're actually not having any experiences between the time of their injury and the many years that have passed, which in this case is 12 years. And you see every now and then the case makes it to the news when somebody wakes up miraculously from a coma over many years, and they think they're still in 1991 and the president is whatever president or prime minister was at the time, etc. So we were really, really interested to see whether he was having any experiences that of these years, whether he was being conscious of the time that was passing. So we asked him a few questions about his cognitive abilities, whether he was oriented in time, and he was, he knew the year, he knew he was in a hospital. We were conducting our scanning in a hospital in this case. He could tell us the name of new children in the family that had only been born since he had in this condition. He can tell us the name of caregivers that he had only met during this condition. So we know that he has some certain level of awareness of things that have been happening in the 12 years that he was in this condition. We've tested this with other patients and we obtained similar responses. And then we wanted to give this patient a little bit of agency over his life. Obviously, if you're in one of these conditions, everything is decided for you. So we want to ask questions. Obviously, you might be thinking about all the questions that we might be asking these patients, but obviously, and we can have a chat about these later in the questions. Obviously, you shouldn't ask anything that you're not prepared to act upon, and you have to consider whether the patient has the capacity to make decisions about their care. So obviously capacity is a continuum, so we're going to ask questions that we think require a low level of capacity in this case. And there's a huge line of research trying to see whether we can use these tools to assess capacity in patients with brain injury that I'm not going to talk about. But in this case, something really small, just deciding what type of programs were played for him. This was in Canada, so hence the ice hockey. What type of shows he was being shown on the TV, and a very important one for the family, which was whether he was in any physical pain. The family was really interested to know whether he was suffering, and there was something that we could do about alleviating that physical suffering in this case. So this is really interesting. We know that 20% of patients can follow commands that are unconscious. A smaller percentage of patients can do this task. Not all of them can. This is really, really complex. But it's a significant number of patients who would otherwise be considered to be entirely unconscious, and in this country probably in a care home for many, many years, until eventually they die of something else, because body-wise they're healthy, they've recovered from the injuries of that brought this condition in the first place. So we've got really, really good, and I'll just have a couple more slides just to end on a positive note. Like, we've got really, really good at diagnosing these patients and at telling families, okay, yeah, your relative is conscious and now we can communicate. But obviously, if I need to bring them here to the CHPH, for instance, the Centre for Human Brain Health down the road, to put them in an MRI scanner, for 5 minutes every time I want to know the answer to a yes/no question, that is not a useful or practical way. It's good as a proof of concept, but it's not something we can use on a day-to-day basis for these patients. So one question that we thought about, and we can't do much else to help these patients recover or have a different clinical journey after we've identified these capabilities, sadly. So this is what we've tried to work on for the last however many years, try to focus, okay, so can we actually understand what's going on here? Why can't they just play tennis? Or why, in kind of more scientific terms, why can't they just move the hand? Why can't they imagine move the hand? They can move the hand, but why can't they bring these two things together to just move the thumb reliably, consistently, and then use this to communicate? And then you might think of the locked-in syndrome, and the locked-in is not a locked-in syndrome, so, but it's just an example. So the locked-in syndrome is a clinical condition where patients had a very distinct damaged base of the brain, where you have the red cross there, that kind of, if you allow me, disconnects the brain with the body, if you like. It's a very simple explanation, but just for the purpose of understanding. So they don't have any ability to move or to have any sensation, but they're cognitively entirely intact. So this is not it, because my patients are not paralyzed, they can move. But the idea is, can we find a different mechanism for it? And for this, we just ran an fMRI study as well. This is one of my friends, not a patient, where we ask people to imagine they had a tennis ball in front of them and they were either hitting the tennis ball or imagining that they were hitting the tennis ball. And what we could see with the fMRI is that actually the activity involves similar regions, but the way the regions talk to each other is a bit different. And what we can see is that you need the thalamus, which is this bit. Now you have a head from the top, sliced like this. So the thalamus, which is this bit on the base of your brain, needs to send some excitation to your motor cortex for you to be able to transform these plans into something that actually sends a signal to your hand for it to move. So we then used a technique called diffusion tensor imaging, which you may recognize from this cover of Muse's album. So alongside giving us really, really pretty pictures that we can use for artwork, this is basically a technique that allows us to reconstruct the wiring of your brain, if you like. It allows us to reconstruct the physical wires or white matter fibers connecting the different bits of your brain that need to talk to each other to perform a particular function. So we did this in these paradoxical patients who appear unconscious but actually not, and what we could see is that actually there was a physical, like a structural disruption in these fibers. There was damage to these specific fibers that need to be working for your thalamus in this case to send a signal to your motor cortex so you can actually move and demonstrate externally that you're conscious and you don't have to come for very expensive testing in the fMRI scanner. So what we're doing now, and I'm not going to go into it, but I just wanted to end with a bit of a positive note, is we've been working for the last 5 years with MRC funding and some key partners in the private healthcare to try to develop interventions to now try to inject a little bit of energy, if you like, in these residual fibers to make them work harder so that we can get these patients to actually show some level of control over their movement that allows them to show us the level of consciousness and to interact with the world using external movement rather than just modulation of the brain activity. And I'm just going to leave you there. So just to give you the take-home message, fMRI can reveal covert awareness in 20% of patients who appear clinically unconscious. Communication is possible in a small percentage of this, and this is, we think we have evidence that this is caused by damage to a specific part of the motor system that allows you to send responses to your body to move. Okay, thank you very much.